Welcome, everyone, and thank you for the opportunity to join you all today. We're excited to discuss opportunities to advance equitable policymaking in commercial tobacco control. And please feel free to submit questions at any time, and we'll answer as many as possible during our question and answer session at the end, and we'll also provide our email addresses if there are any follow-up questions. So my name is Derek Haar. I am a senior attorney at ChangeLab Solutions, where I work across a range of public health law and policy issues, largely around the commercial tobacco control, as well as preemption and health equity. And I will turn it over to my colleague to introduce herself.
Hi, I'm Jessica Breslin. I am also a senior attorney at ChangeLab Solutions. I work on a variety of areas. But that includes tobacco and preemption like Derek, and also some equitable enforcement and healthy communities work.
For those of you who haven't worked with us before, ChangeLab Solutions is a nonprofit that works across the nation to advance equitable laws and policies that ensure healthy lives for all. We prioritize communities whose residents are at highest risk for poor health, and our interdisciplinary team of lawyers, planners, policy analysts, and more works with neighborhoods, cities and counties, and states to create thriving communities. And we have a packed agenda today. First, we'll look at foundational concepts related to and frameworks for thinking about health equity. We'll then look more specifically at equitable policymaking in commercial tobacco control, outlining a framework for action and discussing several policy case studies. Next, we'll do a deep dive on equitable enforcement, what it is, why it matters, and examples of both equitable and inequitable enforcement in tobacco control and public health more generally. And then finally, we'll outline some additional resources available to you all and answer any audience questions. So before we start, I have to give the spiel as a lawyer. While Jessica and I are lawyers, we are not your lawyers. And at ChangeLab Solutions, we don't provide legal advice or enter attorney-client relationships. Additionally, nothing we discuss during today's session is intended to reflect a view on any specific legislation. The information provided in this session is for informational purposes only. And now I will hand it back to Jessica to kick us off on the substantive content of our session.
Thanks, Derek. I'm going to start us off with some background on what health inequities are and why they exist. So for many people, good health is nearly impossible to achieve across the country. The burden of poor health, from preventable chronic conditions to diseases of despair, fall disproportionately on families with low incomes, on individuals with a low level of education, on children, and on communities of color. We all hear a lot about the social determinants of health, and at ChangeLab, we strive to address the fact that they include historical and continuing injustices. The institutional and structural components of the social determinants of health should be understood as sites for organized and deliberate intervention. And it's also important to recognize that law and policy have been central to creating these health disparities today, and they've made resources scarce for many and created unhealthy environments. Yet those are the same very law and policy tools that we can use to create positive change. At ChangeLab, our experience and our portfolio practice across the nation, as well as research evidence, have pointed to 5 fundamental drivers of health inequity. They are created by and therefore amenable to legal and policy interventions. And I'm going to go through them one by one with some more information. So the first one is structural discrimination. That's the type of discrimination that operates through policies, cultural norms, and institutional practices. It applies a systems-based understanding of differences in power in between many categories of identification. The second one is income inequality and poverty. So at the community level, lack of capital funding or investment can mean fewer health promoting amenities for residents. And at the individual level, less wealthy families often can't afford stable housing, healthy food, reliable transportation, quality healthcare, parental support, or other assets that are fundamental to healthy living. Next, we're looking at disparities in opportunity. And what this basically means is inequitable access to quality education and economic opportunities that create fundamental barriers to healthy living. We also look at disparities in political power. So that meaning those with little political power can find it very difficult to make their problems and needs visible to government and institutional decision makers. Without this meaningful input, laws and policies can disproportionately benefit those with greater power to participate in and influence the legal and political processes. And lastly, the last driver is governance that limits meaningful participation. So that would be governance structures that determine how power is distributed and exercised in decision-making, and these processes shape places as well as access to resources and to opportunities. So when we're thinking about all of these drivers together, they can lead us to a few different conclusions. One, that these 5 factors shape places, social environments, and living conditions. They affect people's daily experiences and they produce unfair circumstances. But they're also lenses through which individuals and communities experience and understand their physical surroundings, their social situations, and life circumstances. They can restrict individuals' ability to lead healthy lives, and they inhibit communities' ability to drive change that's meaningful for them. So it's important that we think about all of these things as a framework. Now that we've talked about what health inequities are and why they may exist, and the fundamental drivers, we should also step back a bit and think about what we mean when we talk about health equity. There are numerous variations and of course some disagreement about how to best define health equity. Some people may not use the term at all, opting instead to use a frame such as fairness, justice, or opportunity. But ultimately the goal is for health equity efforts to be effective, and that can happen regardless of what we call it, so long as we share the same basic understanding of its core tenets. And just as a starting point for us today, the National Academy of Science, Engineering, and Math define health equity as the state in which everyone has the opportunity to attain full health potential and no one is disadvantaged from achieving this potential because of social position or any other socially defined circumstance. As professionals in the field of law, policy, and public health, sometimes we learn about the ways that our field's tools and methods have been used to create and uphold inequities. For example, historically, redlining was a practice of denying important services like mortgages or healthcare to residents in certain geographic areas based on the racial composition of the neighborhoods. Another example would be mass incarceration from the war on drugs, disproportionately targeted, and in many instances continues to target people and communities of color. Given the robust body of evidence connecting health disparities and inequities with racial and socioeconomic segregation and exclusion, it's important to acknowledge that the past harms we've caused while also making a moral case for correcting those injustices through tools of law and policy today. It's important that we communicate clearly about the history of law and policy, and public health helps shift the frame to systems thinking and away from the idea that the individual bears the sole responsibility for poor health caused by decades or in some cases centuries of systemic harm. Of course, significant harms can be attributed to non-governmental actors, but the systemic targeting of people of color and LGBTQ+ populations by the tobacco industry would be one example of this. Law and policy have sometimes ignored or even perpetuated these inequities, but they can also provide an indispensable tool for addressing them. In fact, many of the best opportunities to advance equity exist at the local level. Local governments are often closer and more responsive to the populations affected by policy decisions and can be more responsive to community concerns. They can also drive innovative policies that would be difficult or impossible to pass at higher levels of government. Further, when we're thinking about it, community members should be at the heart of policy change. Equitable policy change must be the result of an effective two-way communication that goes both bottom up and top down. The people most affected by health inequities should direct how to correct that injustice. The key for folks in the policy and public health realms is deep listening, collaborative communication with the communities most affected. So when we're thinking about this, we can tailor our approaches to serve under-resourced communities. This might mean looking at upstream health determinants, and we can often clearly see the complex web of systems and influences that contribute to poor health. This can lead to an understandable desire to want to remove these things from their neighborhoods where they do the most damage. When we're thinking about this, this might be anything from getting sugary drinks out of certain communities, or making sure that there's safe housing. But the problem is that many of the communities that have the greatest concentration of these unhealthy influences are also the ones that are already underserved by the public and private sectors. They may even distrust these institutions and the policies themselves. Because of this, public health professionals should be sensitive to the fact that efforts to remove things, even unhealthy things like cigarette or alcohol or sugary beverages, from already under-resourced and underserved communities may not be well received. This doesn't necessarily mean that we need to stop trying to stem the flow of harmful influences into communities. For example, some of it, like tobacco advertising that heavily targets kids, can be incredibly predatory. But we can start by using this as our guiding question. How can we make sure that we focus just as much, if not more, on bringing healthy influences to neighborhoods rather than only removing unhealthy ones? This is thinking about valuable resources like parks, fresh food, jobs, early education, and things that people need to thrive individually and collectively. And part of helping people live their healthiest lives is giving them power, the power to shift the balance and giving community members a say over what happens in their lives. I know I've just covered a lot of ground today, so I'm not going to address much of this slide in depth, but the key takeaway that I want to stress is that operationalizing health equity is about more than outcomes and reducing disparities. Both of those are, of course, extremely important, but it's also about the process of policymaking, listening, and empowering communities and amplifying their voice, about building resiliency and holding those in power accountable. So now that I've given an overview of equity generally, I'm going to hand it over to Derek to talk about equity in the context of commercial tobacco control.
Thank you, Jessica, for that wonderful overview of the fundamentals of health equity. And I realize that many of us are likely already familiar with these concepts of health equity and the social determinants of health. And it's important to frame high-level legal and policy conversations in this context, to remember why we do what we do and to align priorities as we discuss the many options and infinite contexts for doing our work. So how do these concepts fit within the tobacco control movement, a movement that experienced many incredible and undeniable successes long before health equity or social determinants entered the public health lexicon? So the tobacco control movement has made some truly incredible progress in reducing smoking and tobacco use rates, as well as tobacco-related harm across the board. Many of these gains are directly attributable to legal and policy interventions like smoke-free air and increased access to evidence-based counseling and cessation support. However, a just society ensures that no person, especially a young person, is exposed again and again to experiences that we know are harmful. We need to do more to address the number of young people using harmful tobacco products like cigarettes, e-cigarettes, and cigars. Because as we know, early use of tobacco makes long-term addiction to nicotine more likely. And health problems stemming from early tobacco use are higher in rural communities, low-income communities, and communities of color, as well as among other populations, such as people who identify as LGBTQ and people with lower educational achievement. And in some instances, these relative disparities have even grown larger over time. So it's clear that our work in commercial tobacco control is far from complete, and that as we move forward, we must continue to push to reduce disparities and these gaps in smoking prevalence and tobacco-related harm. And these health disparities tell us the story of who is disproportionately affected. but they don't tell us why certain populations are at greater risk for and disproportionately bear the burden of tobacco-related health harms. As Jessica was talking about a moment ago, health equity fills this gap by looking beyond the numbers to the social determinants of health. Effectively addressing these social determinants and reducing tobacco-related health inequities requires us to take an equity-first approach to tobacco control policymaking. For example, we know that although the US has steadily expanded tobacco protections since 1964, with less smoke in the air and fewer advertisements for harmful products, these protections, which many Americans now take for granted, are less likely to cover the places where structurally disadvantaged groups live, learn, work, and play. And we also know that lower income communities experience high levels of pressure. Put simply, fewer resources means more stress. Without options for good jobs, good childcare, or good homes, the pressure of daily life increase. And add that to these neighborhoods being flooded with advertisements and discounts for tobacco products, and that they're also unlikely to have grocery stores that sell fresh produce, thereby making it difficult to get healthy food. When stressful circumstances are compounded by factors like lower quality diets and higher rates of tobacco exposure, the combined forces increase health risks. So to really move the needle, we need to address these root causes within the broader context of the day-to-day commercial tobacco control work. A health equity approach also requires that we ensure that how we talk about tobacco control takes into consideration the unique context and lived experiences of individuals and communities, because how we talk about something influences what we do or don't do about it. As one example, how many people have referred to cigarette or alcohol taxes as sin taxes? I know that I certainly have and am guilty of doing that. But if we call something a sin tax, we're reinforcing the notion that some people are virtuous and others are sinful, which suggests that those that are sinful, quote unquote, are deserving of poor health, which of course is not true. But identifying the need to apply health equity principles to tobacco control is one thing. Really operationalizing those principles is more challenging and not something that we can solve overnight. This slide outlines 3 questions that I often find myself revisiting whenever thinking about the potential equity implications of a particular policy. And of course, this is a very simplified exercise that can't possibly capture all of the nuances or replace community voices, but it can provide a helpful starting point. So first, who is the individual or community that has been harmed? Second, who stands to benefit from a particular policy and how exactly would they benefit? And then finally, how can we prevent future harm? Menthol provides a really great example here. When we think about the populations that face the greatest tobacco-related harms, many are the same populations that the tobacco industry systemically targets with menthol cigarettes: youth, African-American communities and other communities of color, and LGBTQ+ communities, among others. So any equity-focused approach should take these disproportionate harms into consideration. In this light, the federal ban on flavored cigarettes, which explicitly exempted menthol, while an undeniably important public health policy, was also not necessarily an equitable approach to tobacco control because it failed to address the product responsible for so many tobacco-related health inequities. It's another example of how underserved communities often get negotiated out of vital public health protections. Now, it's important to recognize that it's often necessary to take incremental steps. But in doing so, it's also important to remember that the quote unquote easy wins may be the ones that least impact the status quo. These easy wins can be necessary to gain momentum, build hope, and get people committed for the longer haul and larger game-changing successes. But there needs to be a strategy with longer-term plans that build small and large successes over time. Whatever change-making effort is at hand, it's important to bear in mind that easy wins may not maximize equity and may in fact leave certain people behind. So let's take a look at how we might apply this framework to some other specific policy examples. So one other policy we can look at, and one that recently made national headlines, are employers adopting policies against hiring individuals who use tobacco or other products containing nicotine. Now, many states have laws prohibiting employers from refusing to hire or otherwise penalizing individuals who use tobacco while off duty and away from their employer's premises. These laws, which are often referred to as smoker protection laws, were enacted following widespread tobacco industry lobbying in the early 1990s. And in recent years, some policymakers and health advocates have suggested repealing these employment protections entirely. Now, that's an understandable reaction given the industry's involvement and the need to further denormalize tobacco use. But when examined from the perspective of health equity and an understanding of the 5 structural drivers that Jessica covered, it's not clear that removing these protections will benefit public health or health equity. For example, we know that most people obtain insurance coverage through their employer. So these types of employment policies may result in people who use tobacco losing access to vital health services, including insurance coverage for tobacco cessation medications and counseling support. Additionally, many of the populations facing the greatest health burden, low-income individuals and individuals with less education, for example, also use tobacco at disproportionately high rates. So denying employment opportunities based on tobacco use is likely to have an outsized effect on these underserved populations and further exacerbate health inequities. Research has also found that policies limiting employment based on tobacco use are generally unpopular with the public. So focusing on removing these protections may also reduce public support for other critical tobacco control interventions, such as comprehensive smoke-free policies or eliminating the sale of flavored tobacco products, including menthol. Tobacco pricing policies like excise taxes, minimum floor prices, and prohibitions on the redemption of discounts, coupons, and price promotions also provide a great case study. We know that keeping tobacco prices low by fighting taxes and offering discounts are core to the tobacco industry's playbook, and that the tobacco industry engages in the predatory targeting of underserved communities with these promotions and discounts. As just one example, there's numerous studies showing that in communities with higher proportions of Black high school students, menthol prices are lower and menthol advertising is more prevalent. We also know that policies that increase the cost of tobacco products are among the most effective at reducing tobacco use and tobacco-related harm across all populations, and that the evidence is clear that pricing policies can produce outsized benefits for many underserved communities. Stated otherwise, these policies produce greater reductions in tobacco use and related harm among many populations experiencing health disparities and inequities compared to the reductions that we would see across the entire population. And tobacco taxes can also provide a critical source of revenue to invest in tobacco control, broader public health initiatives, and other community priorities. So just looking beyond tobacco control to sugary drinks, for an example, taxes have been used in Philadelphia to fund universal pre-K and in Seattle to address food insecurity during the COVID-19 pandemic. But taxes and other tobacco pricing policies can be a tricky balancing act between competing interests. And this slide includes some of the possible unintended consequences and things to look out for as we all check our hidden red flags. And I won't go into great detail on these today, but briefly, they're first, regressivity. So regressivity simply means that these policies take a greater percentage of income from lower income people. And by this technical definition, pricing policies are in fact regressive. But we in the public health world must consider this against the backdrop of other regressive factors that underserved communities like communities of color and low-income communities bear a disproportionate burden of unhealthy tobacco advertising, consumption, chronic disease, and poverty. Second, dependency on tobacco sales for revenue. This is pretty straightforward. Governments can become dependent on the revenue from tobacco taxes and therefore on tobacco itself, which can stymie progress in tobacco prevention and control efforts. Third is undesired consumer adaptation. So depending on how policies are designed, creating incentives to move from one product type to another. Fourth, it's critical to pair pricing policies with other public health and tobacco control strategies moving the needle through multiple interventions across a period of years. So this includes strategies to offset the regressivity of tobacco pricing policies, like ensuring access to free, culturally competent cessation services, as well as addressing the underlying root causes of tobacco use, such as income inequality. And finally, it's important for decision makers and advocates to seize the opportunity and not stop at the win, but rather to keep in dialogue with community about how the policy is being implemented and enforced, and if its impacts are the same as the ones that were intended. So what are some strategies to equitably direct resources, such as tobacco tax revenues? There are a few big buckets of strategies. First, redirecting resources in the form of staff time, services, and funding to historically underserved communities and towards policies that address their needs and priorities. Second, invest and divest. Effectively funding healthy solutions for underserved communities requires both providing affirmative support, so the provision of cessation services and the addition of grocery stores, as well as alleviating harms, such as reducing access to tobacco products. Affirmative support requires investment. So, for example, using community developed financial institution funds to build housing or grocery stores, while harm should be deliberately removed through disinvestment. And finally, using existing funding streams more flexibly. That might mean blending or pooling together funding or braiding funding, so coordinating separate funding streams to maximize their impact. And ultimately, to eliminate tobacco-related health inequities and tobacco-related harm more broadly, we need to start thinking further upstream about the root causes and social determinants of tobacco use and poor health, from discrimination and poverty that creates the stress that leads people to use tobacco as a coping mechanism, to predatory industry practices that distort consumer choice, to access to education, stable housing, and green space. We need to move from blaming poor health on the individual choices that people make every day towards an understanding of the overlapping systems that influence people's everyday lives. We need to work on the level of changing the systems and structures that unfairly contribute to tobacco use rather than on fixing people. So with that, I will hand it back to Jessica to get us started on our discussion around equitable enforcement.
Thanks, Derek. So before I get into our definition of equitable enforcement at Change Lab, I just want to back up a minute and recognize that some of what we've touched on today is that there's a significant gap between the promise of our laws and people's lived experience. The gap exists in part because laws designed to keep people safe and healthy are often not enforced, or when they are not enforced equitably in a way that promotes health and well-being for the most marginalized people and communities. Enforcement actions taken in the name of public health can sometimes harm, discriminate against, or otherwise undermine the health of the very people the laws are meant to protect. Next slide. So when we're talking about equitable enforcement, we're talking about the process of ensuring compliance with law and policy that considers and minimizes harm to underserved communities. Another important part of equitable enforcement is that it can hold wrongdoers accountable while simultaneously protecting the health and well-being of individuals in the community. Next slide. So when we're thinking about equitable enforcement, we're usually talking about two different things. That's both the under-enforcement and the over-enforcement of laws. So the under-enforcement is when laws that are designed to protect communities are not consistently enforced. So some examples of that would be fair housing laws and local housing codes are laws that are designed to protect the health and safety of individuals by ensuring safe and habitable housing. However, these laws are systematically under-enforced for a variety of different reasons. For example, many housing codes worked on a complaint-based enforcement system, meaning that a tenant would have to complain about a problem before any inspection or enforcement takes place. And there could be a lot of reasons why you might not feel comfortable reporting something like that, or putting for example, like landlord retaliation or putting your housing further at risk. We're also talking about over-enforcement, which is when laws are enforced more frequently or more strictly in certain places or against certain people as compared to others. Existing data suggests that over-enforcement can adversely impact health and compound existing health inequities by exposing the person to greater harm than the law is trying to protect against. So one example of that might be jaywalking. So jaywalking is a law that's designed to protect people from getting hit by cars. But let's say, you're running late for work and you run across the street and you get a jaywalking ticket for $50 or something like that. But then you're unable to pay the ticket because it would mean having to skip paying your rent or having to miss medicine or food. And so then you get a late penalty, and then you can't pay that late penalty either. And sometimes fines can escalate to the point where you get a summons to appear in court. So you get an escalating situation where someone jaywalked and they violated a jaywalking law that was designed to prevent them from getting hit by a car. But instead, now you have them potentially court involved with greater and greater fines that can impact other aspects of their health. Next slide. So when we're thinking about and breaking down enforcement to figure out what equitable enforcement looks like, there's a few different aspects of enforcement that we can take a look at. So the first one is who can enforce the law. So is it the police that are in charge of enforcing the public health law? Is it the public health department? Does it rely on a complaint-based system? Or for example, when we're thinking about smoke-free multi-unit housing, a lot of times there's things in there that would rely on civil actions by private litigants in order to enforce the smoke-free multi-unit housing law. And that requires the ability and the money to navigate the civil legal system. So that's one thing you want to think about when you're thinking about enforcement. Another is who's being targeted for enforcement. So earlier in the presentation, we talked a little bit about individual responsibility versus, the tobacco industry or other predatory industries. So you want to think about, is the enforcement policy targeting the people who are being harmed or the people in positions of powers to actually make change? Next, you also want to think about the roles of victims and communities. We'll get into this in more detail later, but both in the design of your enforcement policies and the implementation or practice of your enforcement policies, you want to make sure that the people who are going to be targeted either for protection or enforcement are involved in the development and implementation of the enforcement policies. You also want to think through whether the enforcement policies have investigative or adjudicatory processes. So going back to the jaywalking ticket, you want to think about how these penalties are compounding and what are the potential negative impacts down the road, or thinking about the complaint-based system. So it's really important that you're thinking about how these enforcement processes are going to be taken out and what are the unintended consequences or potential negative consequences of those processes. And another important aspect of enforcement when you're thinking about doing it equitably is what range of sanctions do you have? So for example, are there non-punitive sanctions, or is it just relying on fines, or is it going to lead to criminal involvement? Are there education processes? And then what are the potential negative impacts of those sanctions? So if you're thinking about smoke-free multi-unit housing, if eviction is on the table, what are the things that you have in place before eviction becomes a penalty, and is that a penalty that you really think will balance the health needs of the individuals most impacted by smoking and multi-unit housing? Next slide. So I'm going to cover just some of the traditional mechanisms of enforcement that we've seen in public health laws. Usually it can break down in either to administrative enforcement, civil enforcement, or criminal enforcement. So administrative might be like an administrative agency such as public health or code enforcement can issue a citation or a notice of violation. There might be an administrative hearing if you want to appeal. A lot of times licensing is done in this way. So if you're thinking about tobacco retailer licensing, there's usually administrative enforcement in that somebody is making sure that they are complying with the terms of the license. There's an agency that's issuing the license and who would be responsible for revoking or suspending the license if there's violations. For civil enforcement, that can also include fines or things like injunctions and evictions. So usually a city or a county can file a civil lawsuit to enforce a law or remedy a wrong or protect a right. So for example, if someone's violating a city ordinance, the city can sue for an injunction or impose penalties, or some combination of the two. And then lastly, criminal enforcement can also include in fines and then jail time or imprisonment. So that would be, let's say there is a law that prevents smoking in parks. There might be a criminal aspect of that. If that you violated, it could be considered a misdemeanor. So that would be criminal enforcement. Sometimes that means a fine. Sometimes it means you might be put on probation or taken to jail if it's a significant problem. So that's a totally different type of enforcement than administrative or civil. And it's important when you're designing your enforcement mechanism, you think about what fits what you're trying to enforce and what would work best in each community. And lastly, this also can include who you're choosing as the enforcing agency, which I touched a little bit earlier. Excuse me. So are the police in charge of enforcing your code, or is there a code enforcement in your city or your county? Would it be public health officials? Things like that. Next slide. So here are some things that when you are designing your enforcement policy that you will want to keep in mind when you're thinking about equity. So the first thing would be graduated enforcement. So what that might look like is something where the first time someone violates something, they have an education process or something that isn't necessarily punitive. And then maybe if they keep violating the ordinance, then it includes more sanctions. So for example, I recently worked on a working group for smoke-free multi-unit housing, and it included for the first time that someone violated, they received cessation support and education around the issue. And then there was a graduated thing where, by the third, if they keep violating, then there's a fine, and it's a smaller fine. And if you do it again, then there's a bigger fine. So you want to think about, are we starting with the harshest punishment, or do we have a different graduated scheme of enforcement? Next, one thing you have to keep in mind is a range of sanctions. So again, that can look like something where for some situations you might have education or community service or something like that. And for others, you might be able to have a fine, or depending on what the policy is and what the community determines is the best intervention, you want to have a range of options. Next, you also want to consider non-putative enforcement measures. So for example, when we're thinking about recent orders that require you to wear a mask in public, there's the difference between making sure that you provide someone with a mask if they don't have one on, versus arresting them or fining them for not having a mask. So it's important to think through what are other alternatives that are non-punitive but can still help solve the problem or get to the point where you have the law in the first place. Another thing to think about is the careful designation of enforcement bodies. My favorite example of this is in Colombia. In order to enforce traffic, like pedestrian traffic laws, they use mimes instead of police. So the mimes will, if someone's not crossing in the crosswalk, let's say, the mime will do what mimes do and show them how to walk in the crosswalk, as opposed to giving that person a ticket for jaywalking. But another, a less sort of funny example, would be like, do you want the police to be the ones who are enforcing this law, or is there a better enforcement body? And lastly, something that's important to consider are guardrails for discretion. It can be impossible to take discretion out of enforcement completely, and you don't necessarily want to. There can also be a lot of negative consequences to zero tolerance policies, for example. So you want to be sure that whoever is enforcing your policy has guardrails for the discretion that they have in the enforcement of that policy. So that might be like guidelines. When am I issuing a violation versus when am I issuing a warning, and things that sort of give the person an idea of what they should be considering when they're deciding when and when not to enforce. Next slide. And here are some more things that you'd want to consider when thinking about equitable enforcement. We've already covered a lot about the role of the community, but one important thing to think about is you want the community to be involved at every stage. So it might be design, but you also want them to be involved in the implementation or ongoing evaluation. So let's say that you are collecting data and the data shows that the enforcement is inequitable. It's being enforced more stringently in one community versus another. You want to make sure you're bringing in those communities to help solve those problems so that the community has an ongoing role in all the different components of enforcement. And one way to do that is to make sure you have funded data collection and ongoing evaluation so that if there are problems with your enforcement policy, that you're catching them and you're able to adjust your policy appropriately. And obviously it's hard to collect data and do ongoing evaluation without adequate funding. But you want to make sure you're thinking about funding for all different parts of enforcement. So sure, there's the data collection, there's the actual enforcement. So for however you're funding officials or whoever is in charge of enforcement, you want to think about whether you have adequate funding for training enforcement officers, things like that. And the training should be ongoing. So you don't want to think of like, oh, we started this policy, we trained everyone, now we're done with that. It should be an ongoing training process. So if you have new people coming in or you have updates to your policy or different approaches that you want to change, that the enforcement officers are being adequately trained on an ongoing basis. And also policy updates. So like I mentioned briefly before, if you are getting the data and evaluation of these policies and seeing problems, that you're able to identify and then update your policy based on what you're seeing. And now I will turn it back to Derek to talk about equitable enforcement, more specifically in the context of tobacco control.
Great. Thank you, Jessica. So now that we have that grounding in equitable enforcement, what it is, why it matters, and some of the key considerations, how do these equitable enforcement principles play out in the context of commercial tobacco control? As Jessica mentioned a few times throughout her overview, smoke-free multi-unit housing policies provide a really good case study in equitable enforcement. We know that studies consistently show that low-income communities and communities of color are significantly more likely to be exposed to secondhand smoke at home, which increases their risk for cancer, heart attacks, strokes, asthma, and other chronic diseases. So reducing health disparities and advancing tobacco-related health equity requires more, not less access to smoke-free environments. At the same time, we need to ensure that these policies are enforced equitably and don't exacerbate existing inequities or harm. So cannabis legalization provides a really great and timely example of that, right? We've seen that even after states legalized cannabis, citations for white individuals decreased, but citations for Black and Latino populations actually increased. And that's reflective of broader trends in enforcement due to implicit and explicit biases. And conscious efforts like the ones that Jessica just covered are needed to prevent those outcomes. And likewise, everyone deserves the right to healthy housing free from secondhand smoke. But we also need to ensure that the enforcement of policies designed to protect people's health don't result in eviction or other health-harming consequences. And we have to consider the broader context in which enforcement occurs. So as Jessica mentioned, the inability to pay fines or an individual's immigration status and how that could contribute to inequitable outcomes. Laws that penalize underage use for the purchase, use, or possession of tobacco products also provide a great example of a policy with the right goal, reducing youth tobacco use, but which ends up being counterproductive in practice. So research shows that youth pup laws are not effective, having only a minimal effect on tobacco use. And in some cases, the research actually suggests that youth pup laws can backfire and increase youth tobacco use somewhat paradoxically. And they also raise significant equity concerns because their enforcement often disproportionately affects youth of color and other structurally disadvantaged populations. Finally, the evidence shows that well-enforced laws targeting retailers provide greater public health benefits than youth pup laws. So given limited enforcement resources, prioritizing enforcement of other tobacco control laws can more effectively reduce youth access to tobacco products. And returning to the three questions that were outlined earlier for applying an equity frame to tobacco control policymaking, we know that youth have been harmed by the tobacco industry's predatory practices, that youth don't stand to benefit from youth pup laws, and that youth pup laws will at best be ineffective and at worst are actively harmful. So given these factors, it's clear that youth pup laws are not an equitable approach to tobacco control policymaking. Another example is school discipline practices, which are, of course, a much larger public health and equity concern, but which are particularly acute in the context of tobacco-free schools policies. As we've mentioned, preventing youth tobacco use is, of course, the North Star of commercial tobacco control efforts. And tobacco-free school policies are a really important component of those efforts. But it's also important to ensure that the enforcement of those policies don't create new or exacerbate existing inequities. We know that as early as preschool, Black students and other students of color face harsher and more frequent punishment than their white peers, and that the use of exclusionary school discipline practices, so things like in-school and out-of-school suspensions, expulsions, referrals to law enforcement, and corporal punishment can increase trauma, toxic stress, feelings of fear and isolation, and they can foster mistrust. And studies show that they're not a particularly effective deterrent, nor do they create safer environments for students and staff. To the contrary, these practices are associated with future disciplinary actions, chronic absenteeism, low academic engagement and performance, dropping out, and a failure to graduate on time. And they're positively correlated with detrimental socioeconomic outcomes, meaning that they could have a lifelong harmful effect on affected youth. So in light of this research, it's critical that tobacco-free schools policies the enforcement of these policies don't reinforce implicit and explicit biases and inequities, but instead use supportive and non-punitive enforcement practices like referral for counseling or restorative justice principles to ensure the efficacy of the policy while also ensuring that they don't contribute to the further marginalization and subordination of youth of color. And I also want to draw attention to a model policy released late last year by the Alliance for Healthier Generation and American Heart Association, which includes a comprehensive tobacco-free school, district model policy, administrative rules, and code of conduct language. The model places a real emphasis on equity and inclusion and ensuring that supportive rather than punitive and exclusionary discipline practices are used to address tobacco-related violations. And this slide includes a link to that model policy. I also want to highlight a recent joint statement on addressing systemic racism in the enforcement of commercial tobacco control laws and policies, which was developed by a consortium of public health organizations. The statement outlines a series of values and recommendations for equitable enforcement practices related to the purchase, possession, sale, and distribution of commercial tobacco products. And it's been endorsed by many prominent public health and tobacco control organizations, including the African American Tobacco Control Leadership Council, American Cancer Society, Cancer Action Network, Heart, Lung, American Public Health Association, Changelog Solutions, where Jessica and I work, Truth Initiative, and others. And I won't go into everything that's included in the statement, but some of the key recommendations include, first, that state and localities that currently rely on police or other traditional law enforcement entities to enforce commercial tobacco control laws should shift that enforcement to public health and other non-police entities. Second, revenues from commercial tobacco control laws, including tobacco taxes, should be used to support public health objectives and advanced health equity. Third, placing an emphasis on repealing existing and resisting efforts to enact new laws that penalize youth for the purchase, use, and possession of tobacco products, and going one step further and ensuring that underage youth who violate commercial tobacco control laws are never subject to fines and mandatory community service. Fourth, consistent with what we just discussed around school discipline policies, ensuring that tobacco-free school policies address violations in a manner that is consistent with health equity and restorative justice principles. So that would include ensuring that law enforcement is not involved in the enforcement of the policy, that student violations never result in suspension, expulsion, criminal referral, or any other punitive response, but that instead students who violate the policy are referred to free evidence-based education, counseling, and cessation support services. Next, a recommendation to apply penalties for violations to business owners rather than to customers or store clerks, to use civil and administrative penalties for most violations, with criminal penalties being reserved for businesses that repeatedly violate the law. Next, which seems like it should be common sense, but of course has come up in numerous instances, unfortunately, is prohibiting the use of physical force against people suspected or guilty of violating commercial tobacco control laws. And that would include a prohibition on enforcement officials initiating contact with an individual based solely on that person's possession of a tobacco product. And finally, a recommendation for states and localities to adopt legal and policy frameworks that facilitate the effective and equitable enforcement of commercial tobacco control laws, such as requiring retailers to obtain and maintain a license to sell tobacco products, holding business owners accountable for violations committed by their employees, establishing tiered penalties for businesses that violate these laws, and ensure that enforcement practices aimed at commercial tobacco retail sales occur in a data-driven, evidence-based, and equitable manner. So that could include, for example, ensuring that enforcement practices don't unfairly target underserved communities, retailers in those communities, and if businesses in certain communities have a greater number or rate of violations, that public health officials should seek to identify compliance barriers and offer technical assistance to help those businesses comply before imposing punitive sanctions on them. And before opening things up for Q&A, I just wanted to take a few moments to run through some resources that may be helpful as you dive into the work of equitable policymaking in commercial tobacco control. So first, Changelog Solutions website, changelabsolutions.org, has a number of free resources, including model policies, playbooks, fact sheets, infographics, and webinars. One example being a fact sheet and infographic on point-of-sale tobacco pricing policies that we co-developed with our partners at Counter Tobacco that go over the equity, public health, and legal considerations for point-of-sale pricing policies like tobacco excise taxes and minimum floor prices. Two resources that, while not specifically about tobacco, speak to broader public health and equity considerations. So first, our blueprint for change makers, which outlines the 5 fundamental drivers of health and equity that we discussed earlier, and how to leverage the unique power and efficacy of local policy solutions. And our equitable enforcement guide, which builds on the content covered by Jessica and myself just a moment ago. We also have a preemption toolkit to help local policy campaigns assess and respond to threatened, proposed, or enacted state preemption. And the toolkit centers equity as the guiding principle throughout it. And in partnership with the Centers for Disease Control and Prevention, Change Lab Solutions has also developed the Public Health Law Academy, which provides free, on-demand, interacting trainings on core public health law competencies, like the past and present of public health law, structure of government, and preemption, as well as on certain hot topics in public health, like public health emergencies, overdose prevention, and legal epidemiology. And overall, Change Lab Solutions offers trainings and webinars, individualized technical assistance, and downloadable resources. So with that, Jessica and I would love to answer any questions that you all have. And we really appreciate you joining us today and want to make sure that you have our contact information and that please don't hesitate to reach out to either Jessica or myself if you have any questions or concerns or we're not able to get to your question during the Q&A session. Thank you.
Thank you all for joining us today. I hope that was interesting and informative, and that I am now off mute. I think we can all relate to that in our new virtual world. And you guys are just stuck with me due to some tech issues. We weren't able to have Jessica join us during the Q&A. But please feel free to continue submitting Q&A as well as reach out to either Jessica or myself via email if you have any questions that come up after today's session. So we do have one question. Like I said, please feel free to continue asking them and we'll get through as many as we can. So the one question we do have right now is whether the attendee understood correctly that not only are tobacco taxes a highly effective tobacco control policy, but that they also promote health equity. And so that's more or less the takeaway message, but there are some important nuances there. So what the real key takeaways that we were trying to emphasize are that tobacco taxes are absolutely one of the most effective proven methods that we have for reducing tobacco use. And that's not just tobacco taxes, but really any policy that is going to increase the price of tobacco products is going to have a substantial effect on tobacco use and tobacco sales. And because, certain populations, like income populations, youth, are more price sensitive, we also know that price increases are going to have a disproportionate benefit or disproportionate reduction in tobacco use and tobacco purchases among those populations. So they do have a anti-disparity effect to them in that they're going to reduce tobacco use more among those priority populations. On the flip side, it is also important to keep in mind, as the presentation mentions, that tobacco taxes and any pricing strategy, they are regressive. So they are going to take up a higher percentage of income from lower income populations. And so ultimately, what that means from a health equity perspective is that, yes, they are effective and yes, they are a valuable tool, but we also have to be cognizant around how we are spending those revenues. Are those funds being reinvested into those communities? Do those communities have a voice in how those revenues are spent? And are we putting in the policies and programs and support that are necessary to offset those decreases in income? So things like free, easily accessible and culturally appropriate cessation services, making sure that they have access to nutritious foods and beverages and things of that sort. So it's sort of a compounding approach, right, where tobacco taxes absolutely are a key strategy and can be equity promoting, but as with many things, the devil really is in the details of how the policy is crafted and implemented and enforced. Seeing we got a few more questions in here. Give me a moment while I read them. So question here, do you think the metaphor of pressure would be useful for communicating the impact of social determinants of health as they relate to other substances like alcohol and cannabis? And I think that's certainly true, right? When we ultimately, look at these substances, my background before working in tobacco control was in opioids and other drug policy more broadly. And we know that, while the immediate acute causes of using different substances can vary, ultimately they all, fall back on those same ultimate root causes, right? So income inequality and poverty and toxic stress and trauma and things of that nature. And so, ultimately, as with the, metaphor of pressure for tobacco, that is, certainly true with, opioid use, alcohol use. People are using these substances for a variety of reasons, but often to, escape the day-to-day realities of life. And so, certainly that metaphor of pressure can be helpful in drawing attention to, what is really driving people to use substances, regardless of what that substance is in the first place. One last question here. So we have municipal ordinances which do not include e-cigarettes, but the concern from our coalitions is that if we ask them to update them, they'll be completely repealed. This person is in Texas, and whether we have any insight or experience with this happening. So of course, that's always a risk. When you open up an ordinance, you're opening it up to the political process and everything that comes with it. And you really, I think that really just speaks to the pre-work that goes into it, before, going into having those conversations with the community to make sure you have, community support lined up behind the changes, and anticipating what the industry pressures and opposition is going to be. And to the extent that you're able to, depending on, your job and your role, and your local laws around lobbying and things of that nature, having conversations with the policymakers ahead of time, so you know where they stand and know, what are the chances of that happening. And then it's ultimately a judgment call, and whether it makes sense to move forward, and whether the benefits of trying to update those ordinances outweigh any potential risk of them being repealed. So we've certainly seen that happen, but relatively rarely. I think it's more often that ordinances get watered down than repealed entirely. But everywhere there is different, and it's really just knowing your local communities. I think that is the last question that we have. So with that, we can close things up. And like I said, please feel free to reach out to Jessica or myself if you have any questions after watching the recording or reviewing any of the materials, or if there's anything that we can do to be helpful as you guys go out into the world and do all of the amazing work that you do to advance equity in tobacco control. And yes, please fill out the evaluation. Echo Andrew's comment.